Well, I'm so excited to welcome everybody to a joint production of Rochester Lifestyle Medicine Institute and IHA in Ann Arbor, Michigan. And we're presenting Lifestyle Medicine Grand Rounds tonight. And the case is a man with cirrhosis, not ready to die. If you'd like to partner with us, you can please reach out to beth.garver@rocklifemed.org. We run 3 Zoom-based facilitated programs that are all ACLM certified. They're socially supportive, interactive, and they're available anywhere in the world. And if you are interested in referring a patient to us, just go to our homepage and you can click on an obvious button there that will allow you to download either a hard copy of the referral form or you can fill out an online Google form. And one more time, these are the programs that we run. These are all ACLM certified, our own 15-day whole food plant-based jumpstart program. And those are the start dates down there. We're going to send a recording out of this video later, so you don't have to worry about that right now. We'll get you'll be notified in a couple of days when this recording will be available. We also run the LIFT project, which is 10 weeks of facilitated Zoom sessions, and then Pivio, which is based on the Complete Health Improvement Program, the granddaddy of all lifestyle medicine programs. So we also, all of our CME programs are free thanks to a very generous donor. We have a program called Jumpstarting Health, which is based on live interaction with participants. So you can actually go through either the Jumpstarting Health, Jumpstart or LIFT project with patients and learn along with them and receive 10 CMEs for doing that. Zach Burns is our case presenter tonight. He's a second-year family medicine resident in Rhode Island. He's a plant-based nutrition advocate and practices medicine to improve the lives of human and non-human beings. He is privileged to work alongside Dr. Michael Clapper in moving medicine forward, a nonprofit helping to build a new generation of physicians who are nutritionally aware and prepared to tackle our chronic disease burden. Zach enjoys mobilizing people around issues of nutrition, animal welfare, and climate change. Dr. Will Bulsiewicz is known as Dr. B, the Gut Health MD. He's a New York Times bestselling author of Fiber Fueled and the Fiber Fueled Cookbook, an award-winning gastroenterologist, and an internationally recognized gut health expert. He has dedicated his life to learning how to hear the gut from the inside out. Dr. B completed a bachelor's degree from Vanderbilt University, an MD from Georgetown, and a master's in clinical investigation from Northwestern. He was the chief medical resident at Northwestern and the chief gastroenterology fellow at UNC, and received the highest award given by both his residency and fellowship. Carrie Graff is board certified in both family and lifestyle medicine. She serves as lead lifestyle medicine physician for Rochester Regional Health in Western New York and works to integrate lifestyle medicine throughout this large healthcare system. She is the co-author of 4-Leaf Guide to Vibrant Health, Using the Power of Food to Heal Ourselves and Our Planet. Melissa Sunderman, another regular panelist, is board certified in internal medicine and lifestyle medicine. She has been practicing medicine for over 20 years and recently began a new practice at Canyon Ranch in Lenox, Massachusetts. Her clinical interests include lifestyle medicine, plant-based nutrition, food as medicine, and sports nutrition. She is an avid endurance athlete and is outdoors as often as possible. Dr. Susan Friedman is our case coordinator. She won't be here this evening. That's me. I'm board certified in lifestyle medicine as well as diagnostic and interventional radiology. I'm the founder and president of RLMI, and I'm a fellow of ACLM. At one time served on the board of ACLM, and I'm the lead author of ACLM's Type 2 Diabetes Bill of Rights. And now, without further ado, we're going to hear from Zach Burns, who will tell us about the liver, a man with cirrhosis, not ready to die. I will stop sharing and turn it over to Zach. Zach, you're on.
So here we go. So the liver, a man with cirrhosis, not ready to die. I'm Zach. I'm a second-year family medicine resident of Brown in Rhode Island. I'm really grateful to be here with all of you and to have this very experienced panel, to have your minds on the case. And so I hope everyone here enjoys learning a few things. I certainly have in preparation. So Mr. L, and by the way, Mr. L has given our permission to talk about him. And I've changed some minor details just to de-identify him. 62-year-old male, history of hypertension, hyperlipidemia, alcohol use, no primary care in years. And he came to the emergency room in March 2022 with constipation. He hadn't had a bowel movement in 3 weeks, aside from some watery brown stools, since he started Miralax around a week ago out of desperation. He's been eating less, he has early satiety, but no dysphagia or weight loss. And asking about his social history, no tobacco or other drugs, but he drinks about 15 drinks per week. He works as a contractor. Family history is benign. Colonoscopy 3 years ago, normal. And he consumes a standard American diet, no specific exercise, but he has a somewhat physical job. So let's get right into it. Here's the first question. How can cirrhosis induce constipation?
So, Dr. Bulsiewicz, you want to talk about the answers we got here, please?
Sure. The correct answer to this question is all of the above. So cirrhosis, we think about it in terms of its effects on the liver, but actually cirrhosis has an effect on the entire body, and that can include gut motility. And so it would be expected that a person could suffer from all of what you're seeing here, the delayed gastric emptying, gut dysmotility. And if ascites is present, then the ascites could potentially delay intestinal transit in a number of ways, but part of it is just quite simply creating pressure on the system and restricting the intestine's ability to move in a way. And then we know that cirrhosis is associated with dysbiosis. Dysbiosis is damage or alteration of the gut microbiome, which has been associated with increased intestinal permeability, and that in itself will also affect bowel motility. So now I will say that 3 weeks without a bowel movement, even if a person has underlying cirrhosis, is, that raises a lot of questions from my perspective as a gastroenterologist. And I certainly would not say that that's typical. But I think that the point or the takeaway for the healthcare practitioners is that when we think about our patients who have cirrhosis, we should be conscious of the fact that they oftentimes can have slowing down of their bowel motility and potentially constipation.
Excellent, thank you. And in the interest of time, we're going to pass on our regular panelists for now. And Zach, is that the answer you were looking for?
It is. You
Perfect.
guys nailed it. So I just wanted to add that this portal hypertension, which may be present in our patient, what it does is it brings edema into the intestinal wall. And that occurs from direct toxicity from alcohol and those enterocytes. Is one mechanism, and then also decreased expression of proteins involved in those epithelial tight junctions. So you end up with intestinal permeability or leaky gut. And it's thought that some of the toxins that then go into systemic circulation are part of the hepatic injury itself. So onwards. On physical exam, we're still in the emergency room. Mr. L has a normal neuro exam, faint bibasilar crackles on auscultation, mild tachycardia, normal, I meant to write normal rhythm, abdominal exam with mild distension, increased liver excursion, but no fluid wave. Okay, initial labs. So here you go. We can see, I won't go through everything, but we'll ultimately compare some labs between now and subsequent testing. Importantly, hepatitis panel was negative. If anyone of the panel wants to weigh in here.
Yeah, Dr. Bulsiewicz, I know you're interested in these labs.
Yeah.
Yeah.
Yes. I think there's a lot to talk about here. So first of all, the thing that I think jumps out to all of us is the bilirubin. The bilirubin is 3.5. This is clearly abnormal. And as a gastroenterologist, the way that I'm thinking about this is, okay, is this of liver origin? Is this a biliary origin? Is there an obstruction potentially? What I would be curious about is, does the patient have abdominal pain that would make me worried about gallstone disease? Because that could very easily present the way that we're seeing here with these transaminases with this bilirubin. But the other thing that we see is an INR of 1.4, and this is abnormal. So when we approach a patient with abnormal LFTs, we should always be looking at the INR and the bilirubin. Ultimately, these are the markers of liver function, whether or not the liver is actually doing its job. And what we see here is, on some level, assuming that the INR is not vitamin K deficiency, the liver does not appear to be properly doing its job. This is not fulminant failure, but the liver is in failure. So then we start to ask the question, what is driving this liver that's not doing its job properly? And the first thing that I'm going to look at is the AST and the ALT. And this is a classic pattern. We are seeing an AST to ALT ratio that is 4-to-1. And when we see a ratio like this, what's important from my perspective is the ratio and not how high the numbers are. This ratio, when it's more than 2-to-1, is suggestive of alcoholic hepatitis. So when it's 4-to-1, it's even more suggestive of alcoholic hepatitis. In a moment, I'm going to mention some of the other things that could potentially give you this picture. But the minute you start thinking about alcoholic hepatitis, it's not how high are the transaminases. The transaminases will very rarely be high. The AST should not be more than 300 typically. And the ALT really will very rarely get above 100 in alcoholic hepatitis. And that could be literally life-threatening alcoholic hepatitis. So you're not going to see the severity of the injury in the transaminases. But what you look at is you look at the bilirubin, the INR. The severity of the injury is reflected in the bilirubin and the INR. Now, there's one last point that I want to make here. I guess two real quick. The first is that in a patient who has liver failure, bilirubin of 3.5, INR 1.4, I immediately am asking the question, are the kidneys intact? And the good news is yes, because ultimately it's going to be kidney injury that's going to threaten this person's life more than likely. That's the most likely cause of death in a person with severe alcoholic hepatitis. The other thing that I look at is the platelet count. The platelet count is 261. Platelets are going to be indicative of the severity of portal hypertension if it is chronic portal hypertension. And the reason why is because as the portal pressures rise, given time, talking months, the spleen will become engorged. It will become enlarged. You have splenomegaly. And when the spleen becomes enlarged, then it starts to consume platelets. And so essentially what will happen is the platelet count will start to drop in proportion to the severity of the portal hypertension. Now, there's an exception to this. If you have an acute increase in portal hypertension, an acute increase, meaning something changed very recently, very suddenly, then you will not see that because the spleen has not caught up yet. So with that in mind, this platelet count being 261, my impression based on what I'm seeing here is this looks like a patient with alcoholic hepatitis. We still need some additional testing to verify this. We don't stop here. We want to do imaging to make sure that there's nothing else going on from a biliary perspective. But my suspicion is that the bilirubin of 3.5, the INR 1.4 are probably related to the alcoholic hepatitis. And this is probably recent onset because if this were more of a chronic cirrhosis, we would most likely see the platelets decline substantially. Real quick, the AST, I just want to comment.
Sure.
AST also is found in muscle cells. So something that can drive the AST up, when you see a disproportionate AST to ALT, it can be muscle injury. And that could be medication related. It could be dehydration or something of that variety. But the point is that if there's any question in your mind, if you're not really sure and it's not fitting together properly, then check a creatine kinase.
Excellent. And somebody asked in the chat, what about GGT level? Actually, Dr. Breaky asked, what about GGT level in this situation? Would that be helpful?
Yeah, so this is a person. When you ask about the GGT, I think the reason why you're asking is because GGT is going to be associated with alcohol use, and it's going to rise in people who are chronic alcohol consumers. So in this setting, it could potentially give us some insights into whether or not this is alcohol-related liver disease. But at the end of the day, I think that the complete picture, like the GGT, to me is not going to be sort of the key piece here. I want to see what the liver ultrasound is going to show. I want to rule out biliary issues, but I also want to see if there's going to be fat in the liver. That's what I expect to see.
Got it.
Ted, can I make a comment or a question to Dr. Bulsiewicz? So on the history that Zach took, he admitted that he drinks about 2 alcohol drinks per week. When you look at our guidelines for men, right, 2 or less drinks per week, which
Per day. I think it was per day.
Falls in that guideline, but yet we see these numbers. So in your experience with, if he's being honest, right, and we don't know what size of the drinks he's consuming, do you see this kind of liver damage with 15 alcohol drinks per week, which kind of fits within the guidelines for a man?
Question. Yeah, it's a good question, Melissa. So the vast majority of the time when it's alcoholic hepatitis, and by the way, like we will get into this more, because you can have alcoholic hepatitis superimposed on cirrhosis, or you can start with alcoholic hepatitis and you can evolve into cirrhosis over time. But when it's alcoholic hepatitis, the vast majority of the time, these are going to be heavy alcohol consumers. In a man, 2 drinks per day is not, or this was 15 in a week. So yeah, so 2 drinks per day, that is not likely to be significant enough to explain that. Now, that being said, if a person has an underlying metabolic injury to their liver, such as they do have non-alcoholic fatty liver disease, they are going to be more prone or more vulnerable to this type of liver injury. I still don't think that 2 drinks a day in a man is going to do it. I will also say though, Melissa, that I have had patients who are, there's a difference between men and women and their ability to chronically hold up against alcohol use. And I've had a number of women throughout my career that it's not alcoholic hepatitis, it's alcoholic cirrhosis. But I've had women who end up with alcoholic cirrhosis who are drinking 2 drinks a day because they're having those drinks with their husband sort of as like an evening unwinding thing. And so my experience is that in women, 2 drinks a day could be too much. In men, the vast majority of the time, it's not going to do this. I would expect it to be more.
Okay. Dr. Graff, did you have a question or comment?
Yeah, I was just wondering, you know, he has a history of hyperlipidemia, but I don't see that he was on a statin. If he was on a statin and drinking that much, I was thinking maybe you might see him get into a little bit more trouble, but it doesn't look like he started on the statin. But Zach, could you verify that he was not in the statin at the beginning?
No, he hadn't been taking any medications regularly. He was not engaged in primary care at the time. I think it was an old diagnosis, and so he came in, he said, well, my cholesterol was high in the past.
Okay.
So let's see what the imaging showed. First of all, we have ascites confirmed on ultrasound, and a paracentesis was performed in the ER with 3 liters out. Okay, CT abdomen pelvis confirmed cirrhosis. No other bowel findings that might have explained that kind of severe constipation. And importantly, there's no evidence of hepatocellular carcinoma. There was evidence of portal venous hypertension and varices. So based on these findings, the GI symptoms, right, the clinical picture, the portal hypertension, varices, ascites, Mr. L has stage 3 decompensated cirrhosis.
Did he show, was there a lot of stool burden on the CT scan? Do you know?
You know, I'm not sure. There must have been, because he hadn't had a bowel movement yet, and actually not until toward the end of his hospitalization. He had been eating less.
Zach? Sorry to interrupt.
Please.
A quick comment is going back to the laboratory results. This is a gentleman who probably developed cirrhosis over the course of time, and then more recently decompensated when he developed alcoholic hepatitis. And that decompensation with the alcoholic hepatitis is likely what is driving the bilirubin and the INR. The cirrhosis is there, it's a problem, but I think the alcoholic hepatitis is what's driving this elevation of those 2 particular labs. And the portal hypertension with the varices, there's, you know, we know it's there because he has the ascites. We know that he has portal hypertension. But my suspicion is what can happen is that a person can have the cirrhosis not necessarily be portal hypertensive. When you activate the alcoholic hepatitis, it actually will drive those portal pressures up. And then this is what you get. You get the onset of ascites, you get the presentation of varices as a result of the acute rise in the portal pressures. So like a question that I would be curious about with this patient is, how recently did the ascites start? How recently did they notice that their urine was tea colored? Because that's when the liver failure started. how recently, if they noticed, did their eyes change or did they notice some yellowing?
And what triggers this? Is this because he thinks that he increases drinking? What's the trigger for it to flip into acute hepatitis?
So the liver is insanely resilient to alcohol consumption chronically. I mean, it's like quite amazing. And it's also completely willing to heal as long as you don't take it to the breaking point. But the way that I would describe this is that the liver with this particular gentleman at this point is like it's been in a championship boxing match with Mike Tyson for 12 rounds. And when you could go into the first round and you could have a champion liver, but by the time you get to the 12th round and you've been fighting Mike Tyson all night, like any of us could walk into the ring and knock you out. And so this is the problem, is that the liver is done. It just has no reserve left.
All right. What's
So-
next, Zach?
So he's admitted, of course. He was really cooperative, and he was grateful for our care. You know what? He had been on a statin and amlodipine. I misspoke before. I don't think that he was taking it regularly, because he didn't have a regular prescriber, but he had some home meds. And we started diuretics, and we gave him a pretty generous bowel regimen, as one does in the hospital. And I wanted to mention that as a DO, I performed osteopathic manipulation. And you can do this to try to induce a bowel movement. But I think more importantly, it helps establish a rapport. And Mr. L and I became close through this. And we had a good professional relationship. And so for the DOs out there, if you can practice OMM for that reason alone, it can be really great. And others, just a caring, comprehensive physical exam can serve a similar purpose.
Let me make a quick comment, Zach.
Please.
So just a quick comment from a gastroenterologist perspective. When we treat these patients with furosemide and spironolactone, the most important thing to counsel your patients is to tell them they need to go on a low salt diet. Because if they are consuming salt, particularly, like, they may not even think of it as salt. They may think of salt being adding salt to their food. But if they're consuming a lot of canned foods, for example, you're going to find that they're going to be refractory, particularly in the setting of ascites, to these diuretics. And then you're going to have to push until it ultimately affects the kidneys. Also, real quick, someone asked the question in the chat, is the relatively high platelet count surprising regarding the severity of the varices? And I would say, I don't believe that it is, because there was no evidence of splenomegaly. If there was splenomegaly, it would be surprising. So someone asked, is it an acute phase reactant? And I don't believe that it is, because what you will see is if you line up 100 people that have cirrhosis, you will find that their platelet count, as inflamed as they are, the platelet count goes down as the splenomegaly increases.
I had a question about, all these folks with cirrhosis are at increased risk for SBP, and is there any increased risk with doing an osteopathic manipulation of the gut for increasing the risk of that?
It's a great question. I think that we'd want imaging first. The paracentesis happened first. I think that he wasn't profoundly distended. So all those are factors that would make me more comfortable performing gentle colonic release. But great question.
And anytime we order paracentesis in the hospital, we should always send it for cell count and diff, just to make sure. You should always verify that there's not SBP.
And Dr. Graff, or somebody just explain to the audience what SBP is, please. It's an abbreviation they may not all be familiar with.
Yeah, spontaneous bacterial peritonitis. So I just saw somebody yesterday who had that, came out of the hospital, left AMA from the hospital after having that. So good times.
Right. Thank you. Okay, Zach.
Okay, so lifestyle discussion. So this is indeed a lifestyle medicine grand round. First of all, alcohol, right, is an addiction, and we need to employ our behavior change strategies, but also nutrition is going to be key for his recovery. And so he and I talked. We had some real talk, and we discussed his recovery, and he was really motivated. He didn't realize how much alcohol was affecting him, and he thought, while I'm at it, This doctor's telling me about nutrition and how powerful it can be. Let's make some changes. So he expressed sincere motivation. He was discharged after a few days with follow-up to PCP, who he requested would be myself. I was very honored, and also with a GI.
Zach, I have a question for you. Obviously, you didn't put him on a plant-based diet while he was completely full of stool. How did you get him unstuck?
So, he was not completely unstuck. He'd had a small bowel movement while in the hospital, but he wasn't totally unstuck. And we just followed up closely to make sure that he had some good evacuations in the following days, which he did.
I'm going to piggyback on Carrie's question. Because we think that there's some liver disease going on, he's not really showing signs of hepatic encephalopathy. Would you ever start lactulose for this reason? Because he's constipated. I didn't see that an ammonia level was drawn. It sounds like he was, had his sense about him, but would you consider that, without encephalopathy as almost, treatment for the constipation and preventative maybe for the hepatic encephalopathy?
Yeah, that's a great consideration. He was totally coherent with us throughout. And so we didn't think of treating him, but prophylactically, I'll pitch it to the panel. Would anyone use it in that case?
I think that the concept behind it is there's definitely nothing wrong with the idea. From my perspective as a GI doctor, I think every patient who presents with liver disease of this variety, we need to be checking them for asterixis. And if there's asterixis, then that is 100% the right choice. In the absence of asterixis, I think that you could debate it because there's not really any literature to support prophylactic lactulose or prophylactic rifaximin. We obviously need to get him pooping, but I kind of feel like, at least for me, it's hard to titrate lactulose. It's not fun for the patient. And so in this guy, I think that there's enough challenges that exist here. So I feel like let's try to keep it as simple as we can, get him pooping, and then let's turn our attention to what we really need to do, which is focus on his liver disease.
Right.
That's
So this next question, I'm pitching him on a plant-based diet, but I want us to think about what are the particular concerns given his hepatic cirrhosis. So go ahead. The panelists want to start, or should I?
Go for it, Zach.
All right, so the crowd is correct. The answer is B and D. So let's go through. So why is B correct? And this is tricky because so branched chain amino acids, they're actually thought to be disadvantageous in non-alcoholic fatty liver disease. We're going to talk more later about the distinction between cirrhosis and the more common non-alcoholic fatty liver disease. But in cirrhosis, you're in a catabolic state at some point. You're breaking down proteins, and so you need to replenish the branched chain amino acids, which are readily found in plant-based foods, including brown rice, beans, lentils, chickpeas, cashews, almonds, and pumpkin seeds. Okay, why is D correct? So in this catabolic state, the liver is going to make, basically there's less glycogen reserve. So you go into a fasting state more easily. Your threshold is lower for that fasting state, and you'll go into gluconeogenesis. Okay, for gluconeogenesis to work, you need protein substrates, and so it's going to pull protein. So those are those two answers. Deficiency. So why is A wrong? Because you can have a protein deficiency in obesity. So there's a lot of sarcopenic or low muscle mass obesity. It's becoming more and more of a problem. And that was honestly likely the case for Mr. L. Letter C, consumption is, these are all estimates, but evidence suggests it should be about 1 to 1.5 grams protein per kilogram body weight. So, thoughts?
Dr. Bulsiewicz.
I think this is a very tricky question, Zach. Who's writing this? Was this you?
Yes. Yeah, maybe it was too mean.
This is a tricky question, but I think that the take home message here is that we worry, and you can see this in your cirrhotic patients, the change in their body habitus and the loss of muscle mass that occurs. And so it does become a priority in terms of supporting them from a nutritional perspective. And the branched chain amino acids, the reason why they're beneficial is because these are the anabolic amino acids, particularly leucine. So in a typical person, you wouldn't want to do this because it increases IGF-1. But in your patient who has cirrhosis, we're not thinking about, 50 years from now or things of that variety. We're thinking about what do we need to do with this person who's losing muscle mass right now to support them. And that's where it makes sense.
So Zach, would you supplement with, are you talking, how do you ensure that people are getting more branched chain amino acids?
I think counseling them on, especially if he's going to transition to a plant predominant diet, making sure that he knows which foods need to be eaten regularly. So I did that. But you have to be, I think this is why I want us to think about cirrhosis, because there are some nuances when we're prescribing plants.
Got it. All right, let's proceed and we'll get to our regular panelists after the next slide.
Okay. So at my clinic, we call it the Meet PCP appointment, the first one. So now we're in April. Mr. L was strongly motivated for alcohol cessation, and he's quit except for the occasional glass of wine on a celebratory occasion. But he denies having the urge to consume more. It doesn't make him want to keep going, and he denies withdrawal. He's also made a pretty dramatic change in his diet. He's largely eliminated meat and processed food, favoring veggies, fruits, whole grains, legumes, nuts, seeds, and spices. So he basically was really excited about this new chapter of his life and went for it. And we're going to start following the weight. Unfortunately, I don't have his baseline weight from the hospital, but it would have been higher. So we can consider this his baseline dry weight, although I think it was a bit up because he was discharged from the hospital at least a month before. Plants.
That was a pretty quick slide there.
I wanted to say
that's your best slide.
Mr. L has turned over a new leaf.
Got it.
So, okay, we have repeat labs at this point. By the time he got them, it was May 12th. Okay, so let's take a moment to look at these significant changes from prior.
Dr. Bulsiewicz, do you want to comment on these labs, please?
Yeah, so I think I'm just going to move left to right and leave a few comments as we move through. So first of all, I'm encouraged that his hemoglobin is still 12. That's great. The MCV of 106 is expected to some degree in a person with a history of chronic alcohol abuse. The one thing that I will say is if he truly is not consuming alcohol, then this should normalize eventually. So this is something that we want to keep our eyes on. The platelet count has declined by 70 points. This is kind of what I was expecting. I think that we're moving, the portal hypertension is now moving towards more of a chronic phase. The creatinine is holding stable. It's a little bit lower relative to where it was 2 months ago. That's probably not a huge thing, but it could be a muscle mass loss element to that. And the bilirubin of 4.2, AST 135, ALT 29, INR 1.3, really, these are essentially the same from my perspective. And what I will say is that there is alcoholic, this is from my perspective, there is alcoholic hepatitis. I think that that's clearly present, and there is underlying cirrhosis. So there are these two conditions. If this patient is truly abstinent, then we will, over the course of months, have resolution of the alcoholic hepatitis that will drop off, and we will be left with the cirrhosis. And the liver is capable of amazing healing, even in these dire straits that we see right now, if he truly abstains from alcohol 100%. And where the bilirubin and the INR land, we will not know until more time passes. It's still a little bit early in the game. So the most important thing from my perspective, I think there's a lot to celebrate about his choices. But the most important thing that I would be reinforcing to this patient is no alcohol, zero alcohol, never alcohol. And we should celebrate the fact that he really has made big steps, though.
That's great. And I'm going to make an executive decision. Zach, keep moving. We're going to actually have to give you about 45 seconds per slide for the rest of your talk. Okay.
That's fine. Yeah, we just spent a lot of time in the front, but that's okay.
That's okay.
So the next visit was with a colleague, and he's stable off alcohol and meat. Quote from my colleague: "Feels excited and energetic. Feels great." July 1st, same thing. We're supplementing B12 and folate at this point for his macrocytosis. And we're going to check those labs. We just wanted to supplement ahead of time. His weight is down to 198, so he's below 200. Hasn't been below 200 in years, he said. We have another set of labs. Now we're in mid-July. So his hemoglobin dropped a point. The platelets are so I think we had, hold on.
It was 165 or 195, yeah.
95 to 135 now. Creatinine's up, so we can be a little assured that he's not losing too much muscle mass if we interpret it that way. T-Billy is comparable. AST, ALT are modestly improved, and the albumin is stable.
Real quick, Zach, I think INR should be checked on this patient every single time we do a blood draw. So we need to know what that is because we're tracking that. And then the other thing is actually I'm not happy with what the creatinine is doing. I'm worried about the BUN and the creatinine both going up. Now, this patient, I assume, is still on diuretics. So I would be assessing their ascites and I would be reducing their diuretic right now. And I would be having them come back shortly for another round of labs because I'm a little worried that this could spin out of control really quick.
Mm-hmm.
Okay. So would you consider it you wouldn't consider it an AKI yet, would you?
I don't know if I don't know if I would consider it an acute kidney injury necessarily, but I think that this is certainly a change relative to where we were. Again, he's on diuretics. We may be pushing him too far. If you keep him on the diuretics that he started on when he had 3 liters off on his paracentesis, that's going to be too much. At some point, we're going to have to back it down. So now is the time where we back it down, we repeat the labs, but we want to keep close tabs on this guy. We don't want to let him get away from us, because if you do, it could be 4 weeks or 6 weeks from now, and he ends up in the hospital with creatinine of 1.5.
Great point. And we do have folate, but so B12 was adequate. Folate was a little bit low at 2.2. So he's eating more plants. The folate's still low. We know that the gut dysbiosis can decrease absorption in the duodenum where folate is absorbed. So maybe he needs to have more folate than the typical person. It's possible. And so he's on supplements at this point.
I think the other thing too is it's been 4 months since this all started. His MCV is still 104. His bilirubin is still 4. His AST to ALT ratio has not contracted. It's still 4-to-1 basically, almost. So I'm a little bit concerned that he may not be telling us the truth about his alcohol consumption, to be honest with you.
Yes, and we will explore. We'll learn a few things coming up. Mid-August now. He comes in. He says he fell off a dock. So remember, he helps build docks. This was summertime in Rhode Island, and he fell off and has extensive bruising on one side. The weight is stable, but his labs were a little alarming. So we're focused on this bottom line with the new labs. Okay, the MCV is up. The T-Billy is up. The INR is 1.8. That's the highest we've seen. And then we got hemolysis labs, okay, which do suggest hemolysis. We also have an iron panel, which does not suggest iron deficiency. So we're working up this anemia, right? Because hemoglobin's down at 9. cirrhosis is associated with extravascular hemolysis. There are a couple of mechanisms. One is you can have increased splenic destruction of the erythrocytes, just like of the platelets. You can have metabolic changes to the erythrocyte membrane. And so the instability of those lipids in the membrane, it can manifest two ways. It can cause the macrocytosis and also induce hemolysis. So there could be a few things going on contributing to his abnormal hematologic labs.
So if I could make a comment on that, Zach. So in a patient who we know has portal hypertension, and we have prior imaging that shows he has esophageal varices, when I see a hemoglobin drop of 2, I need to know what's going on with the varices. I need to know that this is not an upper GI bleed, even if he's not having hematemesis. And we have to be a little bit careful about hemolysis or making the diagnosis of hemolysis in a patient like this, because it's actually rather complicated. Because the expectation, even in the absence of a drop in hemoglobin, if you had checked his haptoglobin probably in July, he may have still had an haptoglobin less than 8. He may have still had an LDH that's elevated. And the reticulocyte count being elevated could happen in a GI bleed. So I think the point from my perspective is that it's quite tricky because patients with cirrhosis, they will have the appearance of hemolysis based upon the classic hemolysis labs. So we have to turn to secondary testing to get a better picture of this. And so things that you might do, first of all, if it's me, I would consult a hematologist, but we should look at a blood smear and see if the blood smear shows schistocytes, which would be evidence of hemolysis. And the other thing is that when there is hemolysis, typically there's going to be consumption of coagulation factors. And you see the INR has gone up. This could be in response to hemolysis, but it could also be in response to his liver disease. Same is true with his bilirubin. Again, it's hard to really separate the two. So another thing that you could look at, if this is a person who's in the hospital, which by the way, with these labs, I would put this patient in the hospital until we clear up what's going on. But another thing that you could look at is a factor 8 level. So there are all of the different blood factors and they're all produced by the liver, but the exception is factor 8, which is von Willebrand factor. So even in a cirrhotic, they will have a normal factor 8 level. But if they are hemolyzing, you will consume that factor 8. And so a factor 8 level in the hospital could potentially help you to bring clarity to this. The issue with it is unless you're in a teaching hospital, you're probably not going to get it back very quickly.
Question for you, Will, with respect to the BUN, with upper GI bleed, we'll start to see BUN going up.
If it's actively occurring in acute, then yes. But if this is a pump here or a pump there, or alternatively, if it's more of a chronic ooze, like for example, these patients can have gastric antrovascular ectasia, which is the watermelon stomach. And the watermelon stomach, it just persistently oozes. And so you're not going to see the BUN, the creatinine go up, but you're just going to start to drop.
All right.
So good stuff. So we ordered a smear. It never panned out. I'm not sure what happened with the lab. We did refer to hematology at this point, and we also encouraged him to follow up with GI, which was the plan on discharge, but he did not make it to the GI. This is not his smear, but I wanted to demonstrate non-megaloblastic macrocytic anemia. So you can see that change in the central pallor where you have this biconcave erythrocyte. You're supposed to have a nice central pallor, but you see that the different shapes. So comes back, he resists. He really wants to stay out of the hospital. He comes back to the clinic in September, and he's doing much better. He continued to work. He is still doing his summer thing. He looks fairly well. He's coherent with us. Weight's back up to 210, and his right leg is swollen. It's quite asymmetric. We get a stat Doppler, rules out DVT, and we increased his Lasix for a time. We order, the other new thing that happens today is we get an abdominal ultrasound. Let's see what else is going on. So another set of labs, this is mid-September. And this is what we have. We focused on the, well, this is what we have. So hemoglobin has decreased further to 8, okay? And what else? INR is 1.7, TBL 4.2. We have similar hemolysis labs, or hematologic labs, I should say, and direct bilirubin is 1.4. Any comments?
I just think it's all tricky because this is a guy who really is not interested in accessing healthcare resources. I mean, he's sort of demonstrated that to us. Well, I mean, to his credit, he's shown up to all these appointments, but you know, he had a very long period where he wasn't going to a doctor. And you know, in a patient who has underlying cirrhosis, one of the things that's sort of a routine part of preventative care is to perform an upper endoscopy at some point and stage the varices, see what's going on. And so to me, my thought is that this is someone that I wish we had an endoscopy earlier in the game.
Right. Any other comments? Hey, why don't we move on, Zach? And we're starting to run out of time here.
Yep. So we have the next ultrasound shows similar before mild to moderate ascites, but also this evolving cavernous transformation of the portal vein. So what this means is that you have venous channels in or around a previously thrombosed portal vein, and it can be a poor prognosis. We had tried to get him in with GI a couple of times, hadn't seen GI yet. He was referred again, and we really encouraged, we need to evaluate your portal hypertension, your liver, and these varices. Okay, we are at question 3. Yes, by 1 percentage point. You guys, you got it. This is tough. The answer is B. And everything else is incorrect. Here's why. You actually have worse absorption of fat-soluble vitamins in cirrhosis. There's less hepatic synthesis of bile, and so you have worse absorption. Why is C wrong? In alcoholic steatosis, you have actually decreased LDL, triglycerides, total cholesterol. So your lipid profile could look better. Remember, this is a different physiologic state in some aspects from non-alcoholic fatty liver disease or even NASH. So you have this catabolic state and you're breaking down the fats. Okay, this one is funky. So D, actually with alcohol, you secrete more very low density lipoprotein, so VLDL. VLDL transports triglycerides to the bloodstream, and this is why we see high triglycerides in alcohol use. So we've all seen that, and this is why it has to do with VLDL. But what's strange is VLDL is actually decreased in non-alcoholic fatty liver disease. So we start to see these distinctions. E, so adipose tissue actually is peripherally, we see the conversion of androgens to estrogen. So that's sort of an opposite. Okay, moving on. I know we're almost out of time. So essentially in November, the truth came out. He said he had a couple drinks 2 weeks ago. He has some extensive left-sided bruising, may have bumped himself at work, and he's in a lot of pain. He can't even move very well. We implored him to go to the emergency room to rule out an internal bleed. And the patient said, okay, I will, but just let me go tomorrow. So we're kind of crossing our fingers for him. He does go to the ER, and on exam, he has this non-tender ecchymosis from his left armpit to hip with sharp margins. He's diffusely jaundiced. His hemoglobin is 5.2. And, we'll skip through some of these unless with the INR is 2, right? And lactic acid is 5.3. So my analysis is that he's in hemorrhagic shock with that kind of lactic acid. And yet he's walking around, brought himself to the hospital despite some limited mobility and pain from that bruising. So what do we think is going on?
Yeah, Dr. Sunderman, you've turned off your mic.
Well, after we've gotten our tutorial with Dr. Bulsiewicz to follow these labs, we're seeing, his platelets now down to 85K, right? Which means that the spleen is sequestering the platelets. Obviously, he's bleeding with a hemoglobin of 5.2. You look at even his vital signs. This is a guy who has a history, was usually used to be on amlodipine, now blood pressure 128/61 and a little tachycardic at 103. He's breathing a little bit elevated. Lactic acid is elevated. He has been drinking with an ethanol level of 99. INR is now up to 2.0, which is the highest it's been. So this is not a good prognosis.
Mm-hmm. Dr. Graff?
Yeah, he's now in a world of hurt, and we're behind the 8 ball considerably with this guy, so he's in trouble.
Yeah. Dr. Bulsiewicz?
Yeah, I think I agree, and I think we have to, where we start is we attack the hemoglobin of 5.2. We transfuse him up. We hope that those transfusions will help to perfuse the kidneys, which are not in a good place right now, and we need to image him to understand this ecchymoses that he has that sounds concerning for a possible retroperitoneal type issue.
Great. Okay, Dr. Brooks.
So we have a CT. Of course, they pan scanned him in the ER. He has a possible splenic laceration underlying a non-displaced left-sided rib fracture. So remember, he may have bumped himself at work, and he's vulnerable with his coagulopathy and with his varices, and this may be what's going on. He was transfused, and he was, because of the trauma, the fracture in this sort of severe clinical setting, he was transferred to the tertiary care center nearby from the other ER. So then he was admitted there, got more blood, and they suspected acute on chronic variceal bleeding. He had a colonoscopy and EGD there with results as shown, and he was discharged home with a slew of new medications. Dr. B, do you agree with the PPI in this case?
I do agree with the PPI in the sense that he has a gastric ulcer that we want to heal. We want to be cautious with our PPI use in these patients because it can sort of predispose them to developing SBP with his ascites. So we have to be like, we don't want to just keep them on this in perpetuity, which is what often happens. But right. I think that the thing from my perspective is this statement of suspected acute on chronic variceal bleeding. I'm just not, it's hard for me to completely rectify what exactly the physicians were seeing during this hospitalization for them to create that description.
The biggest thing that stood out to me was looking at the, he said he bumped himself at work, but he's got a fracture. That's not a bump. The guy was drunk and he rammed into something, fell down, and then he's trying to hide it from everybody. So this is way past time for a very frank conversation with this guy. And it actually really reminds me kind of about the whole lifestyle medicine focus on things that, we think in terms of those 6 pillars, with the front 3 being the most important in terms of health. It's fingers, forks, and feet. So it's toxins, it's what we're eating, and it's our physical activity. But it's the 3 on the back end that sabotage you every time, right? It's sleep, it's stress, and it's love. And in this guy, like, we never really got to, we knew he didn't want to die, but what does he want to live for? And that hasn't been kind of fully fleshed out. What is it worth making these changes? And then the stress, if his only stress management is alcohol, if we don't give him other tools, he's not going to be able to let that go. And we don't really know what's going on with his sleep because we didn't talk about it. But But I think there are really like two big issues on that back end of the lifestyle medicine pillars that really didn't get addressed with him that might have made him a lot more successful in the front end with getting off the alcohol.
That's a great point.
Really
Zach,
good.
can you go back one slide real quick? I just want to point something out that's interesting. This is just out of interest. Number 4, ascending colon wall thickening consistent with colitis. So the radiologist, no offense, Ted, will often call thickening of the colon colitis. It doesn't necessarily mean that there's colitis. Colitis actually is inflammation of the colon. It just means that there's thickening that they're seeing on the imaging of the colon. And Zach, if you go forward one slide, did a colonoscopy to investigate this, and I, depending on the circumstances, that may have been the right choice. But one of the things that you will see in these patients with cirrhosis that have portal hypertension is something that's called portal hypertensive colopathy. And this is the exact location that you will actually see it is in the right colon. And typically it's due to engorgement of the right colon because the right colon is failing to return the venous blood back to the liver because of the portal hypertension. So just something for people to be aware of in these patients with cirrhosis.
Fascinating. So he, the post-hospital, just a couple quick slides. Basically, I haven't seen him since, but we've been in touch by phone, and he's coherent over the phone. He's appreciative. To your point earlier, he was living for his granddaughter. He had a new granddaughter, and so I think it's complicated. He has this powerful chemical addiction, but he also really wanted to be there for his growing family. And so where is he now? Well, he went to Florida for the winter, as he does. At one point, he ran out of diuretics. I sent some down there, and we talked about diet, reiterated certain things. He says that he's been off of alcohol since that scary hospitalization. And I know he hasn't been back to that. Well, we've been in touch regularly by phone. I don't think that he's been readmitted, so I'm hopeful he hasn't relapsed, but now we know that he tends to downplay the situation. He's back next week, and we'll have a follow-up back in my clinic, so I can update you all. Dr. Barnett, I know that some people might have to go. For others,
Sure.
I have a bunch of discussion questions.
Great. Thanks for that, Zach. So we are going to officially end now, but we will move into the lobby, as we say, and invite discussion for as long as people want to stick around. Dr. Bulsiewicz, can you stick around a little bit longer?
Yeah, definitely.
Great. Thanks. Zach, if you could just stop sharing for 1 second. I just want to put up a slide here. And where's my share screen? There it is. So these, if you go to our website, rochesterlifestylemedicine.org, you can see we have these upcoming information sessions and program start dates for the whole food plant-based diet. I'm sorry, for the Jumpstart, which we run every month. We've had over 1,700 people go through that so far. We also run the LIFT project, and you can see there's 2 start dates coming up there. And then Pivio/Complete Health Improvement Program will be running a couple of more sessions. We'll have a couple of information sessions and a program start date in April. We're currently running 2 concurrent CHIP programs right now. So when those are over, we'll start another one. And that is it for what I would like to share. Thank you all for coming. And you should have already received an email with a link to a Google form. Complete the survey and you will be sent a PDF for worth 1 hour of CME. So thank you all for coming. You're officially dismissed, but I hope you stick around for more discussion. So, Zach, why don't we just leave the slides down for now, and just let's see if, I know you have some questions for discussion, but let's see if there's something that comes up in the chat.
Can I ask a question to Dr. Bulsiewicz? So non-alcoholic fatty liver disease, estimated maybe what, 25% of the population may have this? And has it always been there and we just haven't been screening for it? Or why is this an up and coming rising disease state, in such a dangerous disease state? Because we know that this can progress to NASH, and then a decent percentage of NASH can progress to cirrhosis. So can you walk us through that?
Yeah, it's It's concerning, and this is going to be a growing problem with our healthcare system. And so, first of all, the rising numbers of non-alcoholic fatty liver disease are in parallel but lagging behind the numbers that we see with diabetes. So when we look at national statistics of diabetes, specifically type 2 diabetes, we see that it's on a rise, on a level that it's becoming pervasive. And the underlying pathophysiology is very much aligned between these conditions, type 2 diabetes and non-alcoholic fatty liver disease. So it's the insulin resistance that's driving both of the issues. You could have one potentially without the other. They don't have to be existing at the same time, but that the pathophysiology ends up being the same. So, and this is why you see both of these conditions rising. A couple of quick interesting things. First, most cases of cryptogenic cirrhosis, where you don't identify hepatitis C and there's no clear history of alcohol use or abuse, are probably related to this. The second thing is that this is one of the big challenges that we're going to face in the future. People who develop cirrhosis with non-alcoholic fatty liver disease, so they go through that progression that you described, Melissa, NAFLD, NASH, cirrhosis. They have portal hypertension that is disproportionate to the severity of their liver disease. So what I mean by that is that these are people that their bilirubin and their INR is not necessarily that high, but they're having GI bleeds or a lot of ascites, and it's creating a lot of challenges. Many of them are going to ultimately require TIPS as a result of that. So now the good and exciting news, we can talk more about this. I think Zach may have had some questions about this. The good and exciting news is that we know that dietary intervention can improve insulin resistance, that dietary intervention can improve diabetes, potentially, put diabetes into remission. And I believe that the same is true when it comes to non-alcoholic fatty liver disease or non-alcoholic steatohepatitis, that dietary intervention, if implemented early enough prior to cirrhosis, that you can potentially reverse these issues. It's been shown with the Mediterranean diet.
Dr. Bulsiewicz, what would be early tests for non-alcoholic fatty liver disease that would before it becomes obvious?
Well, ultimately, you're going to most likely see it on an ultrasound.
That's why I'm asking, because I get asked we do this all the time. We say, well, the liver is a little more echogenic than normal, so we think it's probably fatty liver disease. But right?
I think we have to call attention to that. I think it's important. I think it's important that we call attention to that, and as a result of that, that we're checking the liver function tests, that we're doing a thorough liver evaluation, including for other stuff such as I know someone mentioned hemochromatosis. So like you would check for hemochromatosis, you would check your viral hepatitis panel, but then we need to drill down on these lifestyle factors. If there's alcohol, we need to take it out of the equation. And if there's other evidence of metabolic dysfunction, then we need to attack that.
Right. Thank you. Is there anybody in the audience who wants to raise their hand, ask a question? Or I know Dr. Brakey, you're out there. Did you have any comments or questions?
Yes, thank you, Ted. I was on vacation, so I couldn't take my usual panel spot, but thanks again, and especially thanks, Dr. Bulsiewicz. We greatly appreciate your wisdom in this, Zach, excellent and complicated case. I guess my question would be, we know that the common ingredient, or the active ingredient in most hand sanitizers is ethanol, because basically it's a broad spectrum antibiotic. Dr. Bulsiewicz, can you comment on how regular alcohol intake might contribute to microbiome dysbiosis and further complicate things for both this patient and others?
Yeah. So specifically with relation of alcohol use and the development of chronic liver disease, it's actually kind of interesting. I think we all know people who consume an excessive amount of alcohol and yet don't seem to suffer these consequences. And the emerging evidence suggests that the dysbiosis, or injury to the microbiome, predates the development of the alcoholic liver disease. So in essence, what we believe is happening is that well before you ever manifest your alcoholic hepatitis or your alcoholic cirrhosis or even alcoholic fatty liver disease, that it shows up in the microbiome first, that this is actually a metabolic issue, and that ultimately then it will parlay into liver damage. So with regard to alcohol and the microbiome more broadly, so probably the safest amount of alcohol consumption is no alcohol consumption. I'm not a big believer that the idea that drinking one drink is like per day is actually to our benefit. There are people who will claim resveratrol in red wine is, beneficial, and that would be true, the resveratrol. But we don't have to drink wine to get resveratrol. You actually find resveratrol in grapes and peanuts and a lot of other places.
Interesting. Yeah, thanks for that. I see Dr. Michael Clapper's in the audience. Michael, do you want to turn your camera on and ask your question personally?
Hi, everybody. Great presentation. Well done, Zach. And hi there, Dr. B. Good to see you, everyone. Well, I'm curious, as this thing unfolded, he came in once with a swollen right leg and never found any cause for that. Did he have a thrombosis of femoral iliac vein, or what do you think might have caused that? But he certainly doesn't have a thrombotic propensity, that's for sure. It's going the other direction there. So any ideas, how would cirrhosis cause right leg swelling? Any idea?
You're muted, Zach. Zach, you are muted.
Thank you. There's some mysteries that remain unsolved. I think, we ruled out DVT with the Doppler in this case. I think in my limited clinical experience, some people seem to have a propensity for accumulating their fluid on one side over the other. But in this case, it was a pretty striking asymmetry. So any other ideas?
Yeah. Any thoughts on that? Huh. The left leg, the left leg is the one that's more likely to get swollen because of the anatomy of the common iliac vein, right? And you can he could have an iliac thrombosis, right? And you wouldn't see that on a ultrasound.
Right,
So
that's what I was thinking.
yeah,
That's what it's about too, is whether there's a deeper vein.
yeah.
He's already on his own anticoagulant, right? He's got an INR 2.0, so
Exactly, right, yeah.
But it's interesting. These patients, it's rather complicated because they're protein C and protein S deficient. And so because of that, they can actually be hypercoagulable, even though their INR is 2, which is shocking, but it's actually possible, believe it or not. So we have to keep it in mind.
Yeah.
Wow.
Yeah, interesting. Jane Dorsey has her hand up.
Hi, could the right leg swell because of the ascites and the portal, the buildup of blood in the liver itself, or swelling that's more on toward the portal vein?
Expect it to be unilateral.
Yeah.
Okay.
Unless he's lying on the same side all the time, right? If he were lying on his right side, because that's where he's most comfortable.
Well, actually, that's an interesting point, because it was the left side where he had the injury, right?
Right. Yeah.
Yeah.
So interesting.
But,
Yeah. Harry,
If you do get a thrombosis in this patient,
have you treated?
kind of comparing it to the patient that I just had coming out of the hospital, who had a thrombosis in his portal vein, and they sent him home on warfarin, but he's refusing to go for regular blood work, so that is just not going to work. So is there an advantage to using warfarin over using Eliquis or Xarelto?
I don't believe so. Not that I'm aware of.
I couldn't find anything when I was looking for it the other day. I was like, oh, I just want to, like, there was no way this was going to be like safe to use in this
It's
guy.
so complicated though. And I think particularly with this patient, it's so complicated because this is a guy who just bled, and there's, so I think there would be tremendous apprehension to put him on any sort of blood thinner because of the recent bleeding. But if you were to take that away and there were an acute thrombosis without that history of bleeding, even in the presence of varices, you might still go for it.
Okay, and you wouldn't have a preference for which anticoagulant you would use? You'd be okay with using Eliquis or Xarelto versus warfarin. You know, the cancer docs want you to use warfarin because they say that it's better, and they would prefer that you not use the others. And but you know, it all depends on whether somebody will actually take it and get their blood drawn regularly, or else you could have a bleeding mess if they're not being careful. And if they're not consistent with anything, then you have no idea how you're adjusting the doses based on what. So,
Right.
okay, I feel better now. Thanks.
Yeah, this is a tough case. Dr. Jill Brooks. And I think this is gonna be our
Hi.
last person. Go ahead.
Okay, just a general question, a little more general than the other ones, but does the Academy of Lifestyle and Medicine endorse any particular alcohol cessation programs or support groups to recommend to somebody?
Good question. I'm not aware. Zach, do you know if there's any?
No, I don't know of any particular groups, but I think the standard ones we think of, everything is relevant to lifestyle medicine. So if AA is going to work for somebody, if other support groups are going to work, then I am happy for them to be involved.
Thank you.
Yeah.
So Zach, is he being followed by any care manager or anything like that on your team to help in between the visits with you guys as far as recommendations and alcohol cessation and things like that? It seems like this would be a great role for like a health coach or something like that to continue the follow-up.
Great point. I think we could involve someone to work with him more closely. What we do have at my community health center is a nurse care manager who tries to ease the transition in and out of the hospital. So that person was involved, but we could have someone following him more closely. Absolutely.
It's also, it's a really good example of why we should be able to practice medicine when one of our patients is out of state. And that you're able to, like, you can actually do an actual visit rather than just phone call follow-ups, and that you don't get paid for or anything. That, having somebody else take over his care in Florida while he's down there is nuts. It's just too complicated.
Yeah, that's a great point.
Why the heck he went to Florida in the middle of all that is also a little bit dicey, but.
Yeah, right. Well, listen, this has been a long day for everybody who had to go to work today. So I really appreciate the panel. And first, I want to thank our partner IHA in Ann Arbor, Michigan. And especially want to thank Dr. Bulsiewicz for helping us out tonight. Your insights were fantastic, and we really enjoyed hearing your wisdom. And I'd like to thank our regular panelists, Dr. Carrie Graff, Dr. Melissa Sunderman, and I think Dr. Bob Ricky. Oh, there he is. He's popped up all of a sudden. Somebody must have highlighted him. And Dr. Clapper, always great to see you. And yeah, so we'll see you next month. All right. Thank you all.
Everyone.
Thanks, everybody.
Thank you.